Bio 550 Human Anatomy, Professor Shelley Brenholt. Please refer to your lab manual for this lecture. You will find the content in the introduction section. In this lecture, I will be describing and giving examples of joint movements. All movements will be described with respect to the body being in the anatomical position. Flexion is the bending of two adjacent body segments so that the surfaces are brought closer together. An example of this would be bending the elbow so that the anterior surface of the forearm and the arm oppose each other. Extension is moving apart of two opposing surfaces. An example of this would be straightening the flexed elbow. Abduction is the movement of a body segment away from the midline of the body. An example of this would be moving the upper extremity within the coronal plane away from the side of the body or the side of the trunk. When speaking of abduction, there's a special circumstance that occurs in the hand and the foot. The hand and the foot have their own functional midline. In the hand, it is the third digit, and in the foot, it is the second digit. So when we talk about abduction in the hand or the foot, we're talking about the digits moving in the coronal plane away from the functional midline of the hand or the foot, not the midline of the body. When speaking of abduction, there is also an alternative naming system that you may hear. Movements away from the midline at the wrist may also be called radial deviation. Movement of the neck or trunk away from the midline is also called right or left side bending or right or left lateral flexion. When speaking about the intertarsal joints, meaning the subtalar and transverse tarsal joints, abduction there is called eversion, where the heel moves away from the midline of the body. Adduction would be just the opposite as abduction. So this would be the movement of the body segment toward the midline of the body. An example would be the upper limb moving toward the midline of the body would be called adduction. Again, the special circumstances when we're talking about adduction of the fingers or toes, one would need to use the functional midline of the hand or the foot rather than the midline of the body. Also, an alternative naming system that is used at the wrist, wrist adduction can also be called ulnar deviation, whereas movement of the intertarsal joints is also called inversion, where the heel moves toward the midline of the body. Internal rotation, also termed medial rotation, is the rotation of a limb segment about the longitudinal axis so that the anterior surfaces face toward the midline of the body. An example of this would be turning the lower limb inward so that the toes point toward the midline of the body. External rotation, also called lateral rotation, is the rotation of a limb segment about its longitudinal axis so that the anterior surfaces face away from the midline. An example of this would be turning the lower limb so that the toes point outward. Now we're going to cover terms of joint movement that are specific to particular joints. At the shoulder joint only, you have a term called horizontal abduction. This is lateral movement of the shoulder in the horizontal plane with the shoulder at 90 degrees. Horizontal adduction would be just the opposite, which would be medial movement of the shoulder in a horizontal plane with the limb at 90 degrees. Radial and ulnar deviation are joint movements specific to the wrist. Radial deviation, also termed abduction or radial flexion, is the lateral movement of the hand at the wrist. Ulnar deviation, also called adduction or ulnar flexion, is the medial movement of the hand at the wrist. Plantar flexion and dorsiflexion describe movements of the ankle. Plantar flexion is moving the top or the dorsum of the foot away from the anterior surface of the leg. This occurs in the sagittal plane and also primarily occurs at the talocrural joint, whereas dorsiflexion is bringing of the dorsum of the foot toward the anterior surface of the leg, again in the sagittal plane. This also primarily occurs at the talocrural joint. Inversion and eversion refers to movement at the intertarsal or foot joints. Inversion is the movement of the foot so that the heel moves medially. Eversion is movement of the foot so that the heel moves laterally. Inversion and eversion of the foot almost exclusively occur at the subtalar and transverse tarsal joints and not at the talocrural or ankle joint. Supination and pronation are terms used at the ankle and the intertarsal complex and foot. Supination and pronation are movements that occur at the ankle and intertarsal complex of the foot and also at the forearm. Supination at the foot describes movements of plantar flexion, inversion, and adduction occurring in an oblique plane about an oblique axis. Foot pronation is the movement of dorsiflexion, eversion, and abduction, again occurring in oblique planes around oblique axes. Supination of the forearm is the rotary movement of the forearm so that the palm of the hand faces anteriorly, and pronation of the forearm is the rotary movement of the forearm so that the palm of the hand faces posteriorly. Specific joint movements that occur at the vertebral column, also known as the IV or intervertebral joints, are forward bending or flexion, backward bending or extension, right and left side bending or right and left lateral flexion, and right and left rotation. Forward bending, also called flexion, is the movement of the vertebral column in an anterior direction. Backward bending, also called extension, is the movement of the vertebral column in a posterior direction. Right and or left side bending, also called right and or left lateral flexion, is the bending of the vertebral column to the right or to the left. This always occurs in the frontal plane. Right and left rotation is rotation of the head, neck, or trunk to the right or to the left around the vertical axis. Joint movements specific to the hip or pelvis are right and left pelvic rotation, which is rotation of the pelvis to the right or the left around the vertical axis. Anterior pelvic tilt, which is the rotation of the pelvis anteriorly around the medial lateral axis. And posterior pelvic tilt, which is rotation of the pelvis posteriorly around the medial lateral axis. These pelvic movements often have accompanied lumbar intervertebral joint movements as well, as described in your lecture notes. Elevation and depression are terms used to describe joint movement at the sternoclavicular joint, which is where the sternum and the clavicle meet, as well as at the scapulothoracic interface. This is a pseudo joint where the scapula and the rib cage meet each other, and where movement occurs between the scapula and rib cage. The scapulothoracic interface is considered a pseudojoint because there's no true bony articulation between the scapula and the rib cage. Elevation at the sternoclavicular joint is the superior movement of the clavicle in the frontal plane that occurs at the SC, or the sternoclavicular joint. Imagine your clavicle as a pen, and the tip of the pen is attached to the sternum, or your breastbone. Elevation is where the end, or the eraser end of the pencil raises superiorly. Depression at the sternoclavicular joint would be the inferior movement of the clavicle in the frontal plane at the sternoclavicular joint. Again, imagine a pencil with the point of the pencil articulating or meeting the breastbone or the sternum, and the end of the pencil, where the eraser is, moves inferiorly. That would be considered sternoclavicular depression. Elevation of the scapula at the scapulothoracic interface is superior movement of the scapula on the thorax, similar to shrugging your shoulders. Depression of the scapular thoracic interface would be inferior movement of the scapula on the thorax, or the return movement of shoulder. During pelvic elevation and depression, the side of the pelvis doing the elevating or the depressing is the contralateral or opposite side to the hip joint where the movement is actually taking place. So pelvic elevation is the superior movement of one side of the pelvis, whereas pelvic depression is the inferior movement of one side of the pelvis. In a closed chain movement, it is the opposite or the contralateral side where the actual hip joint movement is taking place. We will go through closed chain versus open chain at the hip joint further down in this lecture. The terms protraction and retraction are used to describe joint movement at the sternoclavicular and, again, the scapulothoracic interface. Protraction at the sternoclavicular joint is the anterior movement of the clavicle in the horizontal plane where the movement is taking place at the sternoclavicular joint. So again, picture that pencil as your clavicle with the point of the pencil articulating with the sternum or the breastbone. And protraction would be the anterior movement or movement of the eraser end anterior in that horizontal plane. Retraction of the sternoclavicular joint would be just the opposite, and that would be posterior movement of the clavicle in the horizontal plane, with the movement occurring at the sternoclavicular joint. Protraction at the scapular-thoracic interface is the anterolateral movement of the scapula on the thorax. Because of the contour of the ribs, these movements do not occur in a single plane, but are multiplanar and multiaxial movements. Scapulothoracic interface retraction would be the opposite of protraction, where the scapula moves posterior medially on the thorax. So scapulothoracic interface protraction and retraction would be as if you were squeezing the shoulder blades together and then spreading them apart. Posterior and anterior long axis rotation is described at the sternal or movement at the sternoclavicular joint. Posterior long axis rotation is where the clavicle is rotating posteriorly along its long axis at the sternoclavicular joint. Again, picture the clavicle as a pencil, and the clip of the pencil or pen is facing anteriorly. Posterior rotation would be where the pen is rotating so that the clip moves posteriorly. Anterior long axis rotation is the anterior rotation of the clavicle around its long axis at the SC joint. Again, picture that pencil or pen with a clip on it. The clip is anterior, and now the anterior rotation would make that clip rotate even more anteriorly. Or if you picture the clip starting facing posteriorly, the anterior rotation would be where the clip rotates anteriorly. Posterior long axis rotation occurs primarily with overhead movements, whereas anterior long axis rotation occurs with the return of overhead movements. Anterior tilt occurs at the acromial clavicular joint when there's anterior movement of the superior aspect of the glenoid fossa at the acromial clavicular joint in the sagittal plane. Posterior tilt at the acromial clavicular joint is the posterior movement of the superior aspect of the glenoid fossa at the acromial clavicular joint, again in the sagittal plane. When picturing acromial clavicular joint movements, think of the clavicle again as your pen, and now think of the eraser end of your pen or pencil being stationary, and the acromion is moving on the clavicle. When looking at movement of the acromioclavicular joint, we use the superior aspect of the glenoid fossa as a reference. The acromioclavicular joint also has movements of upward and downward rotation. Upward rotation of the acromioclavicular joint is described as the superior rotation of the acromion process on the fixed clavicle in the front plane around the AP axis. Downward rotation of the acromioclavicular joint is described as inferior rotation of the acromion process on the fixed clavicle in the frontal plane around an AP axis. Upward and downward rotation is also used to describe movement at the scapulothoracic joint, actually scapulothoracic interface. Upward rotation at the scapulothoracic interface is a rotational movement of the scapula on the thorax so that the inferior angle of the scapula moves superior and laterally. The glenoid fossa in this case faces more superiorly, whereas downward rotation of the scapula-thoracic interface is rotational movement of the scapula on the thorax so that the inferior angle of the scapula moves inferior and medially. The glenoid fossa then faces less superiorly. Now we are going to describe the terminology used in closed chain hip movement. Closed chain hip movement refers to the movement when the femur is fixed and the pelvis is doing the moving. Hip movement occurs in the three cardinal planes around their perspective axes. Movement in the sagittal plane is called anterior pelvic tilt and posterior pelvic tilt. Anterior pelvic tilt is the anterior movement of the pelvis, where posterior pelvic tilt is the posterior movement of the pelvis. To demonstrate this, I'd like you to stand up so that your femurs are fixed. Place your hands on your ASISs, which are the protuberances at the anterior aspect of the pelvis. And to demonstrate anterior pelvic tilt, I would like you to tilt the anterior portion of the pelvis closer to the femur. To demonstrate posterior pelvic tilt, I'd like you to try to tilt your pelvis posterior so that your fingers move further away from the femur. Notice during anterior pelvic tilt that the angle of flexion at the hip gets smaller, whereas in posterior pelvic tilt, the angle at the hip gets larger. Just as in open chain hip flexion, the angle at the hip gets smaller, whereas in open chain hip extension, the hip angle gets larger. So anterior pelvic tilt in the closed chain form is similar to open chain hip flexion. Posterior pelvic tilt in the closed chain limb is similar to hip extension in the open chain limb. To demonstrate coronal plane movements in closed chain at the hip, stand on one leg. This leg is your fixed leg, also known as your weight-bearing side or support hip. Now move your pelvis in the coronal plane in such a way that your non-weight-bearing hip moves upward. This is called elevation of the opposite side of the pelvis, or contralateral pelvic elevation, or hiking of the side of the non-support hip. Now move your pelvis in the coronal plane so that the non-weight-bearing side of the pelvis moves down. This is called depression of the opposite side of the pelvis, or contralateral pelvic depression, or lowering of the side of the non-support hip. Now think about the pelvis as it's changing in relationship to the weight-bearing femur. The angle between the medial aspect of the femur and the inferior part of the pubis increases with elevation of the opposite side of the pelvis, also known as contralateral pelvic elevation. Now think about what happens to that same leg if it is in open chain. This angle also increases with open chain hip abduction. So one could say elevation of the opposite side of the pelvis in closed chain is similar to abduction of the same hip in open chain. During depression of the opposite side of the pelvis, or contralateral pelvic depression, the angle between the medial aspect of the femur and the inferior part of the pubis decreases, just as it decreases in open chain hip adduction. So depression of the opposite side of the pelvis, or contralateral pelvic depression, in closed chain movement is similar to open chain hip adduction. To demonstrate horizontal plane movements about the vertical axis in a closed chain hip, stand on one leg. Now move your pelvis in a horizontal plane so that the anterior aspect of the pelvis faces toward the non-weight-bearing side. This movement is called rotation of the pelvis to the opposite side, or contralateral pelvic rotation. Now, still standing on the same leg, in such a way that the anterior aspect of the pelvis faces toward the weight-bearing side as much as possible. This is called rotation of the pelvis to the same side, or ipsilateral pelvic rotation. While performing these movements, think what happens when you do closed chain rotation of the pelvis to the opposite side. Can you see that this is similar to open chain hip external rotation, whereas rotation of the pelvis to the same side in closed chain is similar to open chain hip internal rotation. The functional classification of a joint, for our purposes in this class, will be defined as the number of cardinal planes and axes the moving bone osteokinetically and independently moves in and around. Independently means that the creation of the motion at the joint is via your own actions. You do not need to manipulate the bone from an external source to create the movement. So in describing the functional classification of a joint, we think about the axial classification, meaning how many axes the joint moves around, plus how many planes that joint moves within. So for example, the hip is considered or classified as a multi-axial joint with 3 degrees of movement because it has 3 axes and 3 planes that it moves within. The elbow is described as a uniaxial joint with 1 degree of movement because it moves around one axis in one plane. So a joint that can independently move in one plane around one axis is classified as a uniaxial joint with 1 degree of movement. A joint that can independently move in 2 planes around 2 axes is classified as a biaxial joint with 2 degrees of movement. A joint that can independently move in all 3 planes around all 3 axes is classified as a multi-axial joint with 3 degrees of movement.